Waiting for our jazzy intro.
We're going to have to go ahead without the program just crashed. Go ahead.
Oh, okay. Then I'm happy to begin. So good afternoon, everyone, and welcome to this week's Black Health Trust program. We're so pleased you've chosen to empower yourselves again today by joining us. And as always, it's great to have our regular attendees back and those new to the program. My name is Michelle, and I'm the program announcer for today. I hope everyone's doing great. Today, our discussion will center on the long-term effects of COVID-19 and the long haul syndrome. The panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation in Los Angeles and President and Founder of Black Health Trust. Dr. Maxey will introduce his awesome co-moderators, Dr. Ivan Walks and Dr. Salafu today, as well as our guest panel. So Black Health Trust was founded in response to the coronavirus global pandemic and Dr. Randall Maxey's personal and urgent desire to keep his own family safe. And fortunate for us, his commitment to informing his tribe evolved into a much larger vision and for the larger community. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer their expertise and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. That said, I'm going to read our disclaimer. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather than opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, participants, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to be specific to situations. Again, we strongly encourage all attendees of the program to consult their own legal and medical professional for conclusive guidance on how to proceed in your own personal circumstances. So now I'll share a few housekeeping norms. The program is live and is being recorded on different public platforms like Facebook Live and YouTube. By your voluntary attendance here, you understand that if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device that you can control to block your picture and mute your voice throughout the program. That said, all participants will be muted by our Zoom technician initially, and we ask that you remain muted unless the host or moderator asks you to contribute. With regards to the chat room, if you have any questions, and we hope you do, you can enter them into the chat room, but please limit your questions to 2 questions per topic being addressed at a time. And please do not use the forum to advertise or promote your own personal products. We'll get to as many questions as we can. So that said, we are in this together, and we are still in this together after a year now. If this program is and has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support BHT, Black Health Trust, so we can continue to bring our community outstanding content. Visit blackhealthtrust.org or email social@blackhealthtrust.org for more information. If you do send an email to social@blackhealthtrust.org, please just include your first and last name as well so that you can be added to our mailing list. If you don't want to be added to the mailing list, please just indicate that in your email. Thank you so much. So speaking of thanks, we want to thank the Black Health Trust Steering Committee, the Executive Board, the Black Health Trust Virtual Administrative Assistant, who has been outstanding in our organization, our media, production, and Zoom technician, couldn't do it without you, BHT supporters, and all the people behind the scenes for their time and efforts that make this program possible. Now let's also welcome and thank in advance all of our distinguished physicians and special guests. We thank you for sharing your valuable time, your information, and educated insights with us today. Your participation and support help to empower our communities of color, and this is critical, as you know, to our present and future well-being as a people. Black is beautiful and knowledge is power. Welcome again, everyone, to the Black Health Trust Weekly Program. This is our community, this is your community, and this is our time to take our health seriously. Grab your tea, coffee, whatever helps you lean in. Dr. Maxey, please do us the honor of beginning the program. Dr. Maxey, there you go.
Okay, I had to unmute. Thank you very much for everybody joining us. I appreciate our wonderful hostess, and, Michelle Simmons, and my co-moderators, Dr. Barbara Neighbor-Stevens and Dr. Ivan Walks. We have a good session planned today. We've had a lot of questions about the long haul syndrome and what happens after you've been exposed, either knowingly or unknowingly, to COVID. And we know that there are some consequences of it, and everybody doesn't get away on that. But prior to going into our introduction, I wanted to show you what we're doing with our website, if you're not familiar with it. And we're going to have a lot of resources there. I'd like Ms. Shakini Stevens just to share her screen.
Sorry, I didn't catch that. Try tapping above to edit.
Share her screen for a minute and show the website and just give us a very brief overview.
My pleasure. So this is our website to date. The address is blackhealthtrust.org. As soon as you go to the page, you'll see this pop up that asks for your first, last name, and email address. If you do enter that information, that will add you to our mailing list. We have some new exciting features. We'll be able to update in real time a banner at the very top that'll give you the information for what's coming up in the next week. Also pertinent announcements. We're adding more content. We'll have information under each of these headings that you can click on for resources for things such as COVID-19, mental health, preventative care. We also have updated our schedule. You can now go to the schedule and click on the link and be taken directly to the broadcast. So that's a great new feature we have there. We have all of our previous broadcasts archived. You can go directly to any program you'd like to see. It's also searchable by date and topic. So if you're wanting to find something from any of our broadcasts in the past, it's now really easy for you to find. We've updated our experts tab. We have our medical advisory group, as well as now a place to highlight our speakers and thank them so much for joining us on the broadcast. We have a resources tab where we're going to be adding articles that are pertinent to items that are discussed on the program. We have links loaded to credible sources for information about things we've discussed, a link for second opinion experts. If you're in need of a second opinion, Biometric Second Opinion Experts is a wonderful opportunity for anyone, and there's all the information for that right there. We also have, we will soon have a working link for different items that we think would be great for the community, like the airlock mask that was discussed one Sunday. We have made it easy. If you'd like to donate, you can click the donate tab in a really simple form for quick and easy donations. And then you can also join the Black Health Trust. It's free. Your membership in the future, as we grow, there'll be countless resources that you'll have access to by being a member. So if you have a moment, please take just a few moments and become a member of Black Health Trust as well.
Thank you very much, Shakini. I'd also like to make note that I've asked Dr. Helen Davis to be in charge of our editorial and academic content, and members of our medical advisor will be posting articles and other points of interest. And I'm also honored to ask Dr. Jordan Despanning to serve as our Chief Science Officer. You'll recognize him from all of his talks on vaccines. And with that, I'd like to introduce my stellar co-moderator today, Dr. Ivan Walks. Dr. Walks, I haven't been on your couch, but I probably need it as a psychiatrist. Would you have a word? And since I'm having difficulty seeing the thing, introduce yourself. He's been previous Commissioner of Health for the city of Washington, D.C. He trained originally at UCLA in psychiatry and has a distinguished career, been advisor to both the Secretary of Health, Tommy Thompson, during the Bush administration, as well as to President Bush, and was honored to go over and give the Pope some advice too. Dr. Walks?
Good afternoon, Dr. Maxey. I'd like to start off by saying I felt really good when I met with you last week and you told me that I was looking very nice. Then I realized that your sight has been challenged the last couple of weeks. So that I'm gonna have to take that comment with a large grain of salt. But it is an honor to be here, and I was just reflecting on some of the professionals that you mentioned that are connected to the Black Health Trust, and what a joy, what a blessing to have you able to bring this group of folks together. It's really fabulous. One of the people I can see in the corner here is Reverend Pointer, who I know is an official advisor to the Black Health Trust and just really concretizes the link between health and faith and the faith community that we have. So I'm just very excited and honored to be a part of what you've brought together. With that said, let me go right to our data for today, because I'm really excited about talking about the long haul and learning about the long haul, what they call long COVID, that some people are struggling with. Our data, as you know, comes from the day before. And as of 8 p.m. last night, we have the Centers for Disease Control and Prevention, we have the CDC data. So total US cases reported by the CDC, 30,897,028. And just a quick comment, that's what the CDC knows. That doesn't include all the people that thought they had something, didn't get tested, didn't get reported, couldn't find a test in their neighborhood. So I think we're all agreed that at best that number is low. Total new daily cases, same kind of thing. These are folks who were able to find a test and get tested. So 81,376 yesterday. Total US deaths, 558,028 deaths in the US. And total US daily deaths, 904. At some point, we will talk more about how this global pandemic and syndemic is impacting us and how we're connected. Our deaths are 904 as of yesterday. A couple of days ago, Brazil reported 4,000 deaths in one day. This is not going away quickly. And even after you recover from it, it's not going away, which is what we're talking about today, this long haul issue. Total vaccine doses administered, 183,467,707, with some fits and starts. I know most of us have probably heard that there was a significant quality glitch in one of the vaccine manufacturers in the Baltimore area, and that's going to put some of the vaccination deliveries behind potentially over the next several days. The good news of that is that they do have the quality processes in place, and they caught what was going on before any vaccine got close to getting out to anyone. So that gives us some reassurance. And though we do have some concerns about different doctors feeling different ways about the complete and total safety and efficacy of the vaccines, I want to remind everyone that the Black Health Trust has gone through the data from the manufacturers, from the FDA, from the National Medical Association, and then through the Black Health Trust's own review, and recommend that folks do talk to their doctor. And unless they have some overriding health issue that their doctor tells them, we're recommending that folks get out and get the vaccine and get whichever one is approved by the FDA and is coming to your community. Don't believe you're going to get a choice. Don't believe they're going to come back next week with a different vaccine. Get the one that's available to you. And the next slide, please. One of our other concerns with the process of vaccination is who's getting it. And we know that as we look across the country, and I'm assuming that everyone can read this for themselves. The issue that we have is that every time we look at this, we still continue to see that people of color, and particularly African-American folks, are being vaccinated at a rate that is lower than our representation in the general population. And so we are concerned about that. We know that a conversation about vaccines is not the same thing as vaccine hesitancy. And so we want folks to make sure that the vaccines are available to folks in all communities, and particularly in the communities that are not getting the vaccine at the same rate, which today I want to focus on the African-American community not being vaccinated at a rate commensurate with our percent of the population. So with that, let's
Dr.
move
Walker,
on forward.
Can I ask you a question?
Yes,
I
sir.
have a concern about misinformation in our community, making people confused as to what they should do. And at some point during our conversation, I want to address misinformation, misleading information that many of our people get. And I just got some emails today highlighting the fact that several people died after the J&J. And I looked at the source, and it was basically from the so-called Christian evangelicals. So I want to talk about sources of misinformation at some point during the program, if we have time and if that's appropriate. I think we owe it to our listening audience to give them the best health and medical advice possible, but also to be cautious about some of the stuff that's out there and the purpose of it. I believe we are under attack.
Dr. Maxey, that is such an important point. I keep hearing, and this isn't just with the COVID-19 vaccine. So many times we're hearing things in places where we go, where African-American people go, to tell us, be worried because this is bad for you. And typically it's from people who don't look like us. And if we follow the advice that's there, it's advice that's going to hurt us. It's that old falling for the okie doke, we old people used to say, getting tricked, bamboozled. People are trying to give us information that if we take it will hurt us. And that's why, again, I go back to having the Black Health Trust. This is a place where folks can use it as a clearinghouse. And the fact that you, Dr. Maxey, just said, yes, I heard the same thing you heard, but let's check the source. Let's look at what we actually are advising each other to do, as opposed to, oh, I got this. If I listened to what I got on the internet, I would have refused my vaccine. I would have just drunk some hibiscus tea, because I can't tell you how many people told me that's all I needed to do, and I would never be able to get COVID-19. I may have had some hibiscus tea, but I got my shot too.
There's one humorous story before you carry on that I heard about Dr. Fauci, and they likened him to a lion tamer at the zoo. They say, if you go to the zoo and you see the lion tamer running, you better run. Anyway, take over the show.
I would never try to take over the show, Dr. Maxey. I think that what folks are really excited about is us addressing something that, as you can see from the CDC data, the issue of long COVID is not something that folks are tracking specifically, but it's a big deal. A lot of people are taking months to recover things like taste, minor things. Folks are not really understanding how COVID-19 can impact different organs in the body over a long period of time. And so I'm really excited about us being able to get to that today. So I'm going to kick it back to you, Dr. Maxey, to have us move forward.
Okay, I'd like to introduce and have you introduce someone who I've been a fan of for years and years, Dr. Moro Salafu. Dr. Moro Salafu, when I met him a few years ago, was the chief of nephrology or chief of kidney disease at my alma mater, State University of New York, Downstate Medical Center. And he then was promoted to become chief of medicine at that distinguished university. And I've had the opportunity to interact with him on multiple occasions, and he is a brilliant individual. Dr. Walks, would you read his CV, please?
Yes, and I'm excited to do that, Dr. Maxey, and I'll say why in a minute. Dr. Salafou, currently the chief of the Division of Nephrology and director of the kidney transplant program at SUNY Downstate. This is the part I'm really excited about. Dr. Salafou earned 2 master's degrees in public health and healthcare business administration. Boy, is that an area where more doctors need to be able to be conversant. This whole area of business administration and the business of healthcare, particularly when you can do that in an academic setting and teach it in an academic setting, is just so important. He has directed the Nephrology Fellowship Training Program since 2001, and in 2008 assumed the roles of Chief of Nephrology and Director of the Transplant Program, roles that were crucial to the reconstructing of the kidney dialysis and transplant programs at Downstate. Dr. Salafou's research interests are CKD disease progression, vascular biology, and kidney transplant outcomes. So here, Dr. Maxey has brought another smart person to the show. I'm so excited every Sunday. I get to meet all these people that are able to bring their big brains to this and then share that information with us. So Dr. Salafou, please.
Okay, thank you very much for this wonderful introduction. I actually have been able to be lucky to give a number of talks in this forum. All of them were very exciting and I enjoyed the audience very much. Also, I appreciate Dr. Maxey very much because he's brought a lot of light into this darkness of COVID-19 in terms of trying to educate our people on how to respond and how to access information to be able to protect themselves and their families. We really owe a lot to Dr. Maxey for that. Just a little bit of addition to the CV. I currently serve as the chair of medicine at Downstate. I was the previous chief, but now I'm the chair of medicine. I just wanted to make that clear. But my role today really is introducing my colleague, Dr. Robert Foronji. Dr. Robert Foronji is an amazing physician. He's a pulmonary critical care intensivist by training. He went to medical school at the Thomas Jefferson in Philadelphia. And then he came to Columbia University in New York City to do his internal medicine and fellowship training in pulmonary critical care medicine, where he excelled a lot. And then he was retained on faculty in the early 2000s to study lung epithelium and how we could change the lung epithelium in patients with COPD, that is chronic obstructive pulmonary disease. He excelled very much. Within 3 or 4 years, he was able to create his own laboratory, created mice models of smoking to study this debilitating disease. He rose to the rank of assistant professor at the time, and then he was snatched by Mount Sinai to come and join their system to create a new laboratory studying COPD and other related diseases. I got to know him in my role as chair of medicine at Downstate about 5 years ago. I was looking for a new chief at Downstate for the division, and I got to know him. I called him up, and then he told me what he was doing. I was just amazed. He was NIH funded. He was really a star in his in the field of lung diseases. So based on that, I recruited him to Downstate at the time, and he is currently, and with a promotion at the same time. So he's now associate professor of medicine. During the COVID-19 pandemic, because of his role as chief of the Division of Pulmonary and Critical Care, he was actually our pandemic lead at Downstate. He mobilized the intensive care unit. He was on CNN. He was, New York Times. He was basically ubiquitous in all the newspapers in New York City, addressing the pandemic situation and how we could possibly respond to make patients better in the middle of the crisis. So when I got the call from Dr. Maxey to look for somebody who could give a talk on the long haul syndrome, I saw no one better than Dr. Foronji, based on what he did in the COVID-19 pandemic, his own area of study. He was very delighted and said I would do it. And it was very short notice, about a week or so. So I'm really very honored to be introducing Dr. Foronji. to present to the audience this issue of long haul syndrome. This syndrome, it's an amazing syndrome. We thought COVID-19 will come and within 2 weeks, 80% will get better. Within a month, 95% will get better. And after that, the world comes to normal, but it turns out not to be the case. So we're happy to have Dr. Foronji share some of the medical conditions that have arisen as a result of new knowledge that has come out, now called the long haul or long COVID syndrome. So please join me in welcoming Dr. Robert Foronji.
Thank you very much, Dr. Salafou, for that invitation, for that introduction. Thank you, Dr. Maxey, for the invitation to speak, and to the Black Health Trust. I also want to thank Dr. Salafou because one of the things he didn't mention was, as many of you aware, SUNY Downstate is in East Flatbush, a largely Afro-Caribbean neighborhood. And that's the community I grew up in. So it's a tremendous sense of honor to go back and serve the people that I grew up with, and never was that more the case during COVID. And I hope I was able, in my role, and my team was able to alleviate suffering. Many times we were able to restore health. Unfortunately, too many times we weren't. And I certainly encourage everyone who's listening to go out and get vaccinated. I can talk more about that later. But personally, I am tired of seeing people die from COVID-19. And thankfully, this is now a preventable disease with the vaccine. So having said that, I'm going to start and talk about long-haul COVID-19, which we've discussed previously. I don't know if you can see. Okay, there we go. Let me see if I can control my slides. Oh, there we go. So COVID-19, as Dr. Salafou mentioned, in the first week of illness, it's like a flu-like illness. You'll have fever, chills, body aches, and for many people, this lasts a week or two, and then they're back to their normal health. The reason you hear so much about COVID-19 is that less than 10% will develop serious respiratory disease. And that almost always occurs in the second week or later. So it's not like you catch COVID today and then you end up on a ventilator tomorrow. You catch COVID, you have the flu-like illness, and then you subsequently develop severe lung injury. And that can end you up on a ventilator, and it can even kill you. The virus is a coronavirus, and we've known about these for over 100 years. Many of you heard about the spike protein, and that's what gives the COVID-19 the symptoms that it has. The spike protein can attack intestinal cells, airway cells, kidney cells, so it has widespread effects in the body. Unfortunately, as Dr. Salafou mentioned, we thought when patients recovered that would be the end of it, but sadly that for many patients is just the beginning of their journey when they get over the acute illness. And we now have a greater recognition as time's gone by of this long haul COVID. And in many individuals, they experience relapsing symptoms and cyclical symptoms. They seem to get better. They feel like they're turning the corner, and then they feel the debilitating symptoms come back again. And what are some of those symptoms? So this is a table listing some of these. Body aches, many of them are pulmonary, respiratory symptoms, cough, shortness of breath. I've had people that were marathon runners in clinic who come now and say, I can't run a mile. So this has had a huge impact in their lives. From a cardiac standpoint, it can cause chest pain, arrhythmias, and myocarditis, which is inflammation of the heart, which can be fatal. Like I mentioned before, COVID can can infect your intestinal cells. So it can cause nausea, it can cause vomiting, it can cause diarrhea. And in some individuals, these become chronic. It can affect the oral pharynx, causing chronic sore throat or ulcers in your mouth. It's been known to cause eye changes. And this is an area that causes a lot of trouble for our patients. The constant and persistent neurologic symptoms after recovering from acute COVID-19. This virus gets into your nose. It infects the cells in your nose. And then it infects the olfactory, the neurons that sense smell. And from there, it can get into the brain, and it can cause inflammation in the brain. That can lead to headaches and altered mental status, and it can lead to a loss of sense of smell. So these can be really devastating symptoms for people that suffer from these problems. Now, as a pulmonologist, I'm very familiar with this. For the lay community, may not be as familiar. This is a CAT scan, which is a specialized X-ray of the chest. And these are the lungs, which normally look dark because they're filled with air. And this is the heart and the great vessels. This is someone during the acute phase of COVID. This is someone in the second week of illness who's suffering from respiratory illness. COVID has killed lung cells, and now the lung leaks fluid. Remember I said the lung is air-filled. That's why it looks dark here. When it fills up with fluid, it will look white. And you literally cannot breathe because instead of having air in your lungs, you have fluid. So COVID-19 patients are literally drowning, and that's one of the things that leads to their death. Now, many patients ultimately, in fact, the majority of patients recover from that respiratory illness. But what happens to them long term? And I can tell you from seeing these patients in clinic that they're often left with significant symptoms of shortness of breath. They can't exercise like they used to, or even walk up the stairs like they used to. And when COVID kills the lung cells, new cells have to regenerate. And sometimes in that process, the lung scars, which can make it difficult to get oxygen in. And I would say we're just beginning to learn about the long-term effects of COVID in the lung. Now, many of you in the audience might have had breathing tests. These are tests where you blow into a tube and we can measure how strong the lungs are. One of the tests we do is called a diffusion capacity test. The main job of the lungs is to absorb oxygen into your blood so your body can use it as fuel. The diffusion capacity measures the ability of the lungs to do that. After COVID, sometimes the lungs are scarred, and the portion of the lungs that absorb the oxygen, that's called the alveoli, sometimes those are scarred or damaged, so they're not able to absorb the gas as well. And the diffusion capacity measures that. So this was from a study of people 3 months after they had recovered from COVID. And you can see in mild COVID-19, a quarter of the patients, 1 in 4, had abnormalities in this diffusion capacity test. In other words, they couldn't absorb oxygen as well. That matters because you need oxygen to do work. If you're going to go up that hill, going to go up those stairs, you need to absorb oxygen. If you had bad COVID, moderate or severe, 50% of them had abnormalities. So this is really striking to see this. And it was persisting 3 months later. So I think when patients were originally presenting with this long haul COVID syndrome, complaining of shortness of breath, they were met with skepticism by some physicians. But no, this data is showing it is real. And there were other studies looking at other findings. So these were long-term studies in people that recovered from COVID-19, pulmonary function studies. Most of them showed this problem with the diffusion capacity. But there's another test we do to measure your ability to exercise. We measure how far you can walk in 6 minutes. And the survivors of COVID could not walk as far after recovering from COVID-19. And if you looked at their CAT scan, 86% still had abnormalities months later. So the symptoms they're experiencing are real, and there's a real reason why they're short of breath after recovering from COVID. Now, what about young people? So I'm quoting this data here, which was a collection of studies of people between the age of 18 and 50. And one thing we learned about COVID is COVID really hits the elderly hardest. And those were the people that died to a greater extent. It was less likely people under the age of 50 would die. So these were younger people that they're looking at. So you would imagine they would have less long-term symptoms. But in actuality, the rate of symptoms was pretty high in this community. Fatigue, around 50% had fatigue. Shortness of breath, an abnormal CAT scan. Myocarditis, which is inflammation of the heart. That's very serious. That can cause life-threatening arrhythmias, which can cause someone to drop dead. Up to 25% had myocarditis, or inflammation of the hearts, 12 weeks after recovery. Some had persistent loss of taste. And this is important because, 18 to 50-year-olds, these are people who are at the height of their productivity in some ways. And almost a third of them were not able to return to work, showing the impact of long-haul COVID-19. Now, I talked about the lungs. Let's segue a little bit into how it affects the heart. The virus can actually infect the heart muscle cells themselves. That's called the myocarditis. That's one way it can affect that. We know that from SARS, which was a coronavirus infection that caused the pandemic 20 years ago. Many of these SARS coronavirus 1 survivors had cardiac damage that lasted 10, 15, 20 years. So we worry that we may see the same with COVID-19, long-term cardiac damage in these patients. This can cause symptoms of chest pain, shortness of breath, inability to do exercise. And another thing I think for this community, it's very important to keep in mind, yes, COVID-19 can directly affect the heart, infect the heart. But the other thing COVID-19 does, it scares people from going to the doctor. That should not be the case. Please, people should still follow up with the doctor. It's safe to go to the doctor because a lot of people are dying from heart disease now because they're not going to the doctor for treatment. They're not being diagnosed. And by the time they show up, they have significant impairment in heart function. And we don't want that. We want to catch people early in the stages of heart disease. Here's a schematic of how COVID could affect the heart. As I mentioned, it can directly infect the heart cells and decrease their ability to pump or cause arrhythmias. The other thing COVID can do, when it affects the lungs, that can decrease your oxygen levels, which can put a big strain on the heart, makes it harder to pump blood through the lungs. COVID can actually infect the blood vessels that feed your heart, and they can cause heart attacks. And also some of the medicines that we give to treat COVID can cause cardiac side effects. So it's very complex, and it's a big issue for people recovering from COVID-19. Now, the body is always trying to reach balance. So when you get COVID-19, you need inflammation to kill the virus. And that's what you're seeing here. In the green, you're seeing an immune activation. But if that was left unchecked, the inflammation would kill you. So your body induces anti-inflammatory mechanisms, and those are shown here in red, which eventually resolve the inflammation and allow you to get back to baseline. However, in some people, the anti-inflammatory mechanisms are too strong. And what that can do is, if your anti-inflammatory mechanisms are too strong, you may not be able to fight off the next infection. So we worry that people that recovered from COVID, their immune systems may be too weak to fight off the next infection, which is likely to be a bacterial infection. So this is a major concern for people that recover from COVID-19. So when to worry about long haul COVID-19? If you're having symptoms, persistent symptoms after suffering from COVID-19, that's when you should seek out your doctor. And you want a doctor that's going to listen to you and take you seriously. They shouldn't dismiss this. This is a new disease, and we're learning more and more. We'll have to take a thorough history, may involve doing tests. It's important to rule out other conditions that could explain some of those symptoms. That's why it's important to go to the doctor. Maybe it's not post-COVID syndrome. Maybe you're having signs of a heart attack. So if you're having these symptoms, you need to be investigated. And then your doctor can help you with the management of some of these symptoms long haul. So that's why it's important to follow up with your doctor. So just to summarize, because we're running out of time, long haul COVID is not a rare occurrence. Even in 18 to 50-year-olds, a significant portion of those had symptoms long-term, weeks after. COVID can affect many parts of the body, and that's why it can cause so many different symptoms. Even young people can suffer from the long-term effects of infection with this virus. And remember, this has been around only about a year, so we're still only learning about what this virus does. So we'll learn more information as time goes forward. And if one is experiencing these kind of symptoms, shortness of breath, pains, body aches, headaches, it's important that they be investigated to see whether they're long-haul COVID or whether you have another condition that needs to be diagnosed and treated. And with that, I'll stop and turn it back over.
Thank you so much. This was a masterful talk. And I'll start off the questions. I'll let Dr. Salafu and Dr. Walks and the chat. But I've had a number of patients that have had exposure and have had actual COVID. And the questions that surround them is, how do you walk through the trajectory around their immune response, their hyperimmune response? I like that slide you showed with the red and the green. Can you speak about the dangers of that hyperimmune response and what a physician should do with a person who is now post-COVID? And how do we advise them in a very practical way, doctor?
One of the things I think we do is we have to take their symptoms seriously, and it merits a full investigation just like you would with a non-COVID patient. So a lot of times that may mean if the patient's having chest pain, you're doing stress tests to make sure there's no signs of inadequate blood flow to the heart. If the patient's having chest pain and you knew that they had COVID, you may even want to do very sophisticated tests. Sometimes the only way to tell whether the patient has myocarditis, which is inflammation of the heart due to COVID-19, is to do an MRI. And so maybe that wouldn't be the first test you would do in any regular patient, but maybe in a post-COVID patient, you'd be more apt to do an MRI. And so a lot of times that leads to a lot of testing for these patients. Some of that testing proves not to be fruitful in terms of giving a clear diagnosis, but it's important to do it regardless because we have to rule out other causes. We just can't assume it's long-haul COVID. And I will say, too, is that slide I showed where the green is the too much inflammation and the red is too much anti-inflammation, sometimes you can try things as a doctor. The patient I was telling you about, who was the marathon runner, she went to many, many doctors before seeing me. And eventually we had a long conversation. We did a lot of tests. Some of it I was able to just reassure her that overall the function was pretty good. And then what we actually did is tried a course of steroids, because I think that overactive inflammation might have been a part. And she felt remarkably better when we did that. Now, I'm not recommending that for everyone. This was on a person-by-person basis. But in this example, it seemed to make a big difference for her. So that's why following up with your doctor and establishing a good therapeutic relationship with your doctor is so important.
Dr. Salifu, would you continue with your questioning?
Thank you very much, Dr. Foronji, for wonderful review. This is a very important evolution of symptoms following COVID, and we are still in the learning mode, but you have just simplified everything so well, so thank you. My concern about long haul syndrome is really the fact that we haven't standardized anything yet. For instance, when COVID came, it took a few months before we had CDC issue these standardized questionnaires that when somebody's coming, you can ask, did you do this X, Y, Z? And then the person is either positive or negative, and then you screen them out or screen them in and you take an action. I am not sure that the country has come up with a standardized way to allow the doctor or patients to self-screen or doctor screen, and then so that there is uniformity in how we actually approach the disease. What is your comment on that? Should we be moving towards that direction or not?
I think having a standardized questionnaire, so to speak, could be helpful in uncovering lingering symptoms of COVID-19. Because as I showed from that table in the beginning, COVID-19 can affect almost every part of the body. It can affect the muscles, individuals complain of joint aches, it can affect the heart, it can affect the lungs, it can affect the gastrointestinal tract, the kidneys. So, and very importantly too, neurologically, persistent neurosymptoms. And some of the things we're learning, we don't have all the information yet. My mother-in-law had dementia before COVID, and then she caught COVID. I have to say, her dementia accelerated greatly after COVID. Now, have the studies conclusively shown this yet? No, but I suspect that when we do the studies, we may see that it aggravates underlying neurologic diseases and causes them to advance more quickly than they otherwise would have. That is an important point with certain diseases. Like I have a clinic patient with lupus. She used to follow me for the lungs. Her lungs were fine. She got COVID. The lupus flared tremendously, and it scarred her lungs in ways that had never happened before. So a lot of this, we're still in the beginning, the walking stages of COVID-19, and we're still just learning all the things it does, particularly this part. So I think taking, for the doctors, since we don't have systematic questionnaires that have been put together by our experts, I think what we have to rely on is taking a very thorough history and being detailed and asking about all the systems, because as the talk showed us, COVID can affect so many different parts of the body that we have to be thorough when we're taking a history to uncover symptoms that the patient themselves might not be offering up to us unless we dig a little bit.
Thank you.
This is Dr. Walks, Dr. Frangi. I agree with Dr. Maxey's initial comment. That was really a masterful presentation. It's so wonderful to hear someone who not only knows what they're talking about, but can explain it in a way that is easily understandable. Thank you so much. I found myself feeling sad, just to be really candid. I found myself feeling sad as I was listening to the presentation, because it occurred to me that so many people don't have access to the level of caring and scholarship that you bring to this. When we've seen examples, particularly in communities of color, where folks have gone to the doctor and the doctor doesn't have the kinds of resources to run the kinds of tests and to do the kind of comprehensive assessment that you're recommending. And then of course, there's the dismissive piece that we talk about that's well documented in terms of our disparities in terms of healthcare. So I just wanted, and this is, I know this is an unfair question, but I felt sad when I was listening to you because I know that we don't have the kind of resources that you're talking about. How do you get this information out to the larger medical community? How do you, and this really dovetails, I think, with Dr. Salafu's question about getting some sort of standardized approach. So when people have these kinds of questions, they may feel a little bit more confident that there is a standard that is being established. As we're talking about long COVID, that there's a standard of investigation and a standard of assessment that people may be able to look forward to.
Yeah, I think in terms of COVID-19 and long haul COVID, the standards have yet to be developed. So unfortunately, the physicians kind of have to navigate that on themselves. One of the nice things about being at SUNY Downstate is this is an example of it. I have opportunities to have platforms to reach out to communities that I care about. I grew up in East Flatbush. This is a community that I very much care about. Even during the pandemic, one of the patients that I treated and thankfully was able to get her off, the team was able to get her off the ventilator, was a patient I recognized because she was the woman that bought the house I grew up in. She had bought the house from my parents when my parents moved out of East Flatbush. So it felt like a great deal of satisfaction to come back to the community and serve the people that I grew up with. And there are many opportunities at SUNY Downstate to do that. One of my clinic patients is very active in the NAACP, and I've gone and given talks on e-cigarettes, so that to their local conference, and that gave me an opportunity to speak about an important pulmonary related topic, and Downstate's done a lot of research on e-cigarettes. And another important area where we reach out to the community and we have a platform is our clinic patients. And I feel like one of my jobs in clinic is to, besides to be the physician addressing the medical needs, is to be the teacher and to teach. And I do, you do meet a lot of resistance and a lot of skepticism about the vaccine. And I would say that the skepticism about the COVID vaccine is a lot less, at least amongst my clinic patients, than it was about influenza. I could twist arms. I couldn't get people to take the influenza shot, but it's a little better with COVID-19. Now, I also wanted to address something that someone brought up. I don't think the media helps with the vaccine. They'll say something like 67-year-old man dies one day after getting the COVID vaccine. So I was a little curious about this, and I looked up what is the chance of dying every day when you're 67 years old. And as it turns out, when you're 67 and you're a man, you have a 1 in 15,000 chance of dying every day. So that means if we immunized or vaccinated 15,000 60-year-olds on a particular day, one of them is going to die the next day, right? But the media doesn't tell you that. When you should be concerned is if 10 of them are dying the next day, right? But the media doesn't do that. They'll just present the isolated case, and then you'll have some clinic patients saying, well, I heard so-and-so died, and I heard about this. So it makes the job of educating the public more difficult when you have misinformation out there.
Dr. Fornjay, I appreciate that. I'm going to take a leap of faith. Dr. Salafu, I'm going to give you an idea, and I'd like to speak about it. I'd like to propose that the State University of New York Downstate Medical Center Department of Medicine hosts the first international conference on COVID-19 as it affects communities of color, co-hosted with the Black Health Trust and whoever you think. I'd like to see that happen. I'm so impressed with your faculty and staff and what you brought to the table. I would love you to host that at your university with the experts you have, augmented by others. And I won't ask you for an answer now, but I wish you would do that. I'm so impressed.
Done deal, done. June, let's make it June.
Okay. Very good, very good.
I'm so happy you brought this topic up because we just submitted an NIH application for $7 million to study the same syndrome. We hope to be funded. It's not easy, but we hope to be funded. And if it is funded, we'll start work in May, sometime in the middle of May or so, just a month from now. But it's just timely. We have to bring this topic to light. And I think an international conference focusing on the African American experience and what it means to communities of color for the post-COVID syndrome would just be timely. And I think the longer we wait, the more we are not executing that responsibility. So I'm with you on that one.
Thank you so much. Michelle, are there any questions in the chat?
Not particular to Dr. Frange's presentation, but Cynthia wanted to know if we could repost the immune response slide. Are we able to do that quickly?
Sure.
I think that was actually done just after her request went into the chat.
After her request?
So
okay, just wanted to make sure we covered that. Okay, the other questions in the chat are more general with regard to the vaccine, so we'll wait and get to that later.
Okay, but back to Dr. Frange, that issue that you just raised about the death rate based upon age, and I'm glad that you called me a little bit young since I'm not too far over 50. But I'm concerned that just this morning, one of our very esteemed associates sent me an item about a few people dying the day after the COVID vaccine. So, and what you brought up about the statistics of what that really means. How do we go about good information that's not confusing to our communities? Every day we have a certain group that sends these things, and they're so impressed with finding these outlier things that I believe are just bad and misleading information. How would you think we can correct some of that?
I think it's important for the right people to have a bullhorn, so to speak, and to be able to put these things into context. Now, importantly, I'm not one to say we should completely discount it. I think you should, if we're seeing a number of deaths around vaccination, that deserves to be investigated. But people have to keep in context that we're vaccinating millions of people, and often the people that we're vaccinating are an elderly population. And, you know, unfortunately, death is a statistical certainty for all of us. And there's a rate of death at every age. And if we can put it into proper context, perhaps we can alleviate the fears. Now, the other reality is we're human beings. And I don't care what race, color, creed, people are going to think differently. And there's some people I could speak until I'm blue in the face, and I couldn't, and I've tried until I was blue in the face, and I couldn't convince them to take the vaccine. And part of that is human nature. Personally, I don't think, you know, we should have the right to compel people to take the vaccine. All we can do is give them the best information possible, explain why it's good from their individual standpoint, why it's good from a societal standpoint, why it will be great when we don't have to be as concerned about COVID-19. We can go back to our lives and our communities and hope that that's enough motivation for people to do the right thing.
That is so important and so great. Now, we do know that these vaccines, and often people think that they are approved. They're not. They're approved for emergency use, which means they can be given under the authorization of the federal government. But they are still experimental, but we believe in the face of a pandemic and the 500 and something thousand people dying, that it was worth it to move into that. So we're dealing with the prospects of what probability is. Are there any other questions for our excellent speaker, Dr. Salafu, Dr. Walks?
Do you want to address the question regarding does the virus invade or actually invade the brain? Dr. Walsh, do you see that one? Does the virus?
do.
Okay.
Yeah, Dr. Fonje, can you, because you did show the excellent slides with respect to the coronavirus disease impacting the lungs in that way, and you talked about the virus being able to travel through its impact on the sense of smell and getting up to the brain. Can you speak to that question? Does the virus actually invade the brain through the blood-brain barrier and create clots, or is clotting occurring due to inflammation of the brain's vessels due to an overactive immune system through cytokine storm effect?
We have definitely seen higher rates of stroke and thrombosis in COVID-19 patients. Part of that is one of the things that can lead to blood clot or thrombosis forming is injury of the blood vessels, the endothelium. And the virus can directly infect the endothelium, and then it can kill it. And once the endothelial cell, the blood vessel cell, is dead, there's nothing to prevent clots from forming there. And so I've seen terrible strokes as a consequence of COVID-19 infection. Now, in terms of direct infection of the neurons, some of the earlier studies I was reading said, oh, it doesn't infect the neurons directly. Some of the later ones said, yes, now we have evidence that it's able to do that. And one of the sneaky ways it does it is by, it gets into your nasal passages, gets into those olfactory neurons, which are sort of like a bridge between the brain and the nose. And then from the olfactory neurons, it gets through the blood-brain barrier and into the brain itself. For sure, it infects glial cells, which are a type of inflammatory cells in the brain. So COVID-19 patients get more inflammation. They can get an encephalitis-like picture. And there's recent data to suggest that the virus can actually get into the neurons themselves, the brain cells. Now, what's the consequences of this? That, I think some of the studies remain to be determined. I gave the example of my mother-in-law, and I'm convinced unfortunately, she passed due to her dementia becoming very aggressive the past several months. And I'm firmly of the belief that her prior infection with COVID caused the dementia to become more aggressive. But I can't definitively state that because not all the studies are in yet. But it's my strong suspicion that COVID-19 can aggravate neurologic diseases. And they're looking into whether this is true for Parkinson's, whether it's true for Alzheimer's, but we certainly know that it causes increased risk of stroke.
Let me push you a little bit further on this issue that there may be thrombotic issues in the brain that happen. Is this at all related to platelets and their stickiness or adhesibility? And if so, and I'm not sure it is, would that be alleviated somewhat by things that decrease platelet adhesibility? And would you comment a bit on not only the use of anticoagulants, but things like L-arginine or nitric oxide?
In terms of L-arginine, I remember years ago I was on an IRB panel, and the amount of L-arginine eventually gets converted into nitric oxide, which is a very protective compound. It was actually discovered at Downstate. Dr. Furchgott won the Nobel Prize for discovering it. But you'd have to take quite a bit of tablets. Like, I think the proposal was something like 20 tablets a day. It would be like an enormous amount. I don't know if you'd have room to eat anything else. So some of it is a feasibility issue. Could you actually take enough arginine to really get your nitric oxide levels up? That's a difficult question. Now, when the virus infects the endothelial cell, or the cell of the blood vessel wall, that blood vessel cell dies. And then what you have underneath it is collagen. Collagen is a normal protein in the body. It's sort of makes the framework of all our tissues, gives them structure. And collagen is not supposed to be exposed to the blood, but now it becomes exposed to the blood. And that's when platelets can stick to it, and your clotting proteins can start to stick and form clots, and that's when you get into trouble. So it's a little bit controversial. I haven't seen a lot of data on aspirin and Plavix in in COVID-19. There were studies, we did one here at Downstate, seemed to show a benefit for the use of anticoagulation. And we used to anticoagulate everyone who had signs of increased clotting in their blood. The studies overall are mixed. It's not a clear signal. So the way it is today, some doctors believe in it. And if someone comes in with severe COVID, they'll put them on a blood thinner. Some don't. I don't think anyone is, generally speaking, recommending it for patients that are treating their COVID at home. And blood thinners can have risks. They can increase the risk of bleeding. Sometimes, the bleeding, if it happens in the brain, that can be catastrophic. So these are tough questions that I don't think we have fully the answers yet.
Okay, there's a couple of other questions I'm sure Dr. Walks and Dr. Salafu may have, but I just want to make sure, is Dr. Ron Bailey online?
I don't see him just yet, but there are some more questions that came into the chat. So just let me know when and if we have time to reach those.
Why don't you go ahead?
Yeah.
Okay. So is VSafe documenting any of the long haulers? In particular, the question of VSafe is because we are not encouraging Black people in the community to enroll in VSafe, and maybe we should, as it would make follow-up a lot easier by taking note of those while getting vaccinated previously as COVID. Having COVID, previously having COVID. VSafe, are we able to talk about that?
I'm not that familiar with VSafe, but I would say just in general, the African-American community tends to be unrepresented or underrepresented in clinical trials. So anything we can do to address that is a good thing, because there are differences in how people respond to infections and how they respond to treatments. And we have to make sure that the information, medical information we have is applicable to all communities. And the only way to do that is if we have good participation, multi-ethnic participation in clinical trials.
Okay. And another here, thank you, Dr. Frangé. How would you describe the challenges faced by pediatric patients?
COVID-19, I'm not a pediatrician, but COVID-19 seems to have a more mild course of illness. In fact, children tend to recover quicker from COVID-19, which is why, in general, schools aren't super spreaders when it comes to COVID-19. And there are certain unique infections. There was a post-inflammatory syndrome which resulted in a very characteristic rash that seemed to affect a pediatric population. But in general, they have a milder, more short-lasting infections than an adult population.
Okay, very good. And I guess I'll squeeze another in there. Can you please comment on the effects of early treatment on the incidences of long haul?
Call Ron Bailey.
Dr. Frangé?
One of the keys for COVID is part of the problem is people present too late, and often they'll grapple with their symptoms at home. If someone gets a fever, especially if you're in a vulnerable group, what's a vulnerable group? People in their 60s, 70s, 80s, people with diabetes, hypertension, some form of immunosuppression, asthma, obesity. If you suspect you have COVID, I would get tested quickly. If you're in a high-risk group and you have COVID-19 and you're tested quickly, we could abort the severity of the illness. We have medications that could help. In particular, Regeneron has this antibody cocktail that they can give people that are high risk. In fact, if you come into the ED with a fever for COVID-19 and you're in a high-risk group, they will send you home after giving you this cocktail, if you agree to it. And what this cocktail will do is it has antibodies that are directed against COVID-19. It will knock down your viral titer, the levels of virus in your blood, in your body, quickly. And as a consequence, the virus is not going to get out of hand like it would otherwise. Now, would that lead to less long-haul COVID? I can't say that definitively, but my strong suspicion would be if you abort this illness, you could prevent long-haul COVID developing because the person is not going to get as sick as they otherwise would have. So if people are in one of those vulnerable groups and they feel like they have a flu-like illness going on, get checked. And if they get checked, they can.
My apologies. I couldn't hear what.
If they get checked and they're positive, if they get that antibody cocktail soon enough, in some cases, it could be the difference between life and death.
Very good. Thank you, Dr. Frange. Appreciate taking those extra questions on. Dr. Maxey or Dr. Wilkes, are we in position?
Dr. Bailey will be with us in another 10 or 12 minutes, but I'd like to open the floor to one or two of our advisory members for questions. I see Dr. Lisa Kervin-Dawes, who is in Kingston, who's had a real upheaval of COVID at her hospital. And they don't have the same vaccines we have. And in fact, they've had some difficulties. Dr. Dawes, are you unmuted?
Yes, I am. Thanks for letting me ask this question. And that was an excellent, excellent presentation. Actually, one of the reasons I came on today is we actually have several people, a lot of them in healthcare, who are having long hauler syndrome, and some including heads of several departments. We can get Regeneron if you have enough money. It's imported. We're trying to get it actually to be at the hospital. But I was really interested because we have a huge Black population. Anybody is looking at Jamaica's statistics right now sees that we have a lot of active cases. Actually, we're not recommended for you to visit us at this time with inadequate resources. So for people who are getting most of this stuff are being privately funded, we used some of the stuff off label, which the government is telling us unofficially not to do, but not really stopping us, like ivermectin. We do use all the steroids. I myself, because I cover the COVID ward usually, and I'm head of infection control and got infectious disease thrown on it because we don't really have an infectious disease person at our hospital. And I was doing some of that before. But if we could be actually an arm, because we do need help, an arm of your study, if there's a way, I would love to collaborate. We have a lot of excellent professors in the island, and we have a lot of Black patients with comorbidities. I actually one of the things that I was asked by the head of a hospital yesterday who has long hauler syndrome, and his pulse ox is still 93 to 94% at home. He's about 6 weeks out. Is there anything else? Do I have time to go over what he's taken? Is there anything else that he would recommend? By the way, I did get COVID. Actually, I covered one of your meetings when I was actually actively in COVID. But we do need help. So if there's any way, I would love, we can give you all the patients. I do know the Minister of Health. I'm sure if there is a way of us being involved, I would love to have that done. If there's anything else I can tell him now, because he's at home with 93 to 94%.
What I would say is that some of this will take time. What I tell the patients when they're in the hospital and they're recovering is a lot of times it's beyond medicine at that point. And what has happened is the virus has infected the alveolar cell. Think of the lung as, I'll say this for the lay audience, think of the lung as like an upside down tree. Like the leaves absorb sunlight, the alveoli absorb oxygen. And what happens in COVID is that the virus has a predilection for infecting and killing the alveolar cells, which are which line the pockets of air in the lungs, which absorb the oxygen. Once that happens, what you have to rely on is another set of cells to start growing, moving, replacing the ones that are dead, and then turning into the type of cell that can do the job of the alveolar cell. And the reality is that is a process that takes time. So, and I know of no medicine that can make the lungs regenerate faster than they ordinarily would. And the other thing I would say is age can be a real pain in the neck in this example. When I was a teenager, I ran track. If I twisted my ankle, it hurt for 2 days, and then I felt completely fine. If I twisted my ankle now, I'd hurt for a month or two. You know, as you get older, the body doesn't regenerate as quickly, but it will in most people. And I'm hopeful that his or her oxygen level will improve over time, but it sometimes can be a slow process, especially since a lot of these patients, part of the healing from COVID is they form a little scarring, and scarring creates like a little barrier between oxygen and your blood, so it makes it more difficult to absorb the oxygen in your blood. And for that scarring to get better can take a long, long time. So I can't say that there's a specific medicine we could give to accelerate the process, but I could give words of encouragement that this isn't necessarily how it's going to be forever. It just may take the lungs more time.
Yeah, I was looking at the stats on it. It can be like 30% might be there for a while. But my other question, somebody said recently in a talk that we have here, because he went to another place to be treated, we use ivermectin plus monoclonal antibodies if they can afford it, plus a lot of other things if they can afford it. He did not take ivermectin, and they were saying that if the ivermectin might even help him with the inflammation, and that they are seeing it and using it with people with long-term respiratory. I cannot find that online. So I wanted to know if anybody knew if that's true or any other information. I know the guys are using it. We are a third world country and we do have access to that. It's a lot cheaper for many people. I think when I go back, I'm going to try to see if we can get monoclonal antibodies in the waiting room. As I said, I had COVID and I just took a couple of weeks off. I'm lucky. I really, and I have asthma. So I'm lucky in that I really did not get that sick. It was more psychologically scary. And I was just exhausted, which is why I actually caught it, I think. But that was just my comment. And if there's any, I did tell him I would check today. I'm going to a conference, I'm listening to a conference. And if I could get back with anything that might add him, because he's been home for about 6 weeks. He got COVID about 8 weeks now. And he's only 50 with hypertension and used to be an athlete.
I'm optimistic that better days lie ahead. I don't think ivermectin would help. In terms of whether it helps when you're in the acute phase, there are people that feel passionately about it. I haven't seen conclusive data. The only data that is somewhat compelling is data for steroids for people that are very sick with respiratory disease in the acute illness, and also something called tocilizumab, which is an anti-IL-6 cytokine. But again,
that as well too. We treat a lot of it, so we did get a lot of that. He did not. Interestingly enough, most of the people that we are seeing with long hauler syndrome in the healthcare system did not get ivermectin. We have one of the big corporation physicians now who came in after 3 weeks, basically because they pretty much said you need to go in the hospital treating the oxygen, and even though he was on steroids and everything. And at the time, the government here had said we should not use ivermectin. And he is one of the people heads the Medical Association of Jamaica. So he said, I'm following what they say, Lisa. About 3 days into it, when he was very short of breath, he decided, just give it to me. And we saw a difference in 3 days. That's the only thing we did differently. By the second day, he was feeling better. We use a fair amount of it when we can. I think there's a shortage in the island now. So most doctors here, even looking at some of the studies, say it does help. It is not 100%, and we tell all patients that, but it does seem to help a lot. They've been asking me to write it up, but I have been so swamped.
Maybe that's something we can collaborate with you. Let me ask one last question. I think Dr. Bailey is available, but can you tell us, Dr. Foranjay, for example, a patient that's a 75-year-old Black woman in New York tested positive for COVID and has symptoms of shortness of breath on minimal exertion, not enough to go to the hospital. She hasn't had oximetry done, but just in terms of a general approach to an outpatient like that, what would you suggest?
Well, let's say first I'm going to back up, and let's say she first started to have symptoms, fevers, chills, flu-like symptoms. One of the reasons I encourage people that are in high-risk groups to get checked is if they're positive, perhaps they could get the Regeneron, and I have no financial interest in Regeneron, but perhaps they could get this monoclonal antibody cocktail. Now, after several days, your antibody levels are going to rise. So if we wait a week, it's too late. You really would want to get it within the first 4 days of illness. And if you do get it early enough, it could completely knock down the infection. Now, if this patient is experiencing shortness of breath because of COVID, I know automatically that they're not in the first week of illness anymore. Probably Regeneron wouldn't help them in that situation. I don't even think remdesivir would help them in that situation because the virus replication is not much of an issue the second week. It's all the injury the virus caused, which is causing fluid to leak into the lungs. The second week, some would argue if she's presenting with shortness of breath, she should be evaluated. They should check the pulse oximetry because you'd be amazed, how tough some patients can be. And they'll be like, I'm fine. You put the pulse oximetry on them, their oxygen levels 80%, which is well below what we would want. We want 95% or higher. 80%, it could be considered dangerously low. So they may not even, people have a tendency to minimalize symptoms at times, and people can be very stoic, and people understandably much prefer to be at home. So some people at all costs want to avoid the hospital. But if she were experiencing shortness of breath, I would encourage that person to get evaluated as quickly as possible for the doctors or the medical team to check and make sure the pulse oximetry is okay. If they're having respiratory symptoms, that's a person that could benefit from steroids potentially. Some studies suggest that. I'd say the preponderance of evidence suggests steroids could be helpful. And then the other question is the tocilizumab. In certain cases, patients can be considered for that. But certainly someone who is experiencing any respiratory symptoms with a fever these days should go to be evaluated by a medical professional as quickly as possible.
And you were speaking about steroids as an inhaler, nebulizer.
No, I would, if let's say this is due to COVID, you can give an oral steroid. I've done that for some patients. Let's say I knew her pulse oximetry were 95%, let's say it was a little low, like 92 and 93. I might decide to give her oral steroids because she's having respiratory symptoms and maybe she could stay home.
Like a Medrol dose pack?
Yes. You could even give Decadron as the one that's been best studied for COVID. And you could even give that orally, and that would work. That would work well. I've done that for some outpatients. If her oxygen level were low, like in the 80s, then that person should come in and be treated aggressively, and then we should monitor where things go. Because the other thing to remember about COVID, I lost a very good friend, and probably some of you know him, Dr. James Mahoney. He was my colleague, my friend, my backbone at SUNY Downstate, and he was one of the first people on the front lines during this, and he would not hold back. And he just had a fever the first week, and I would text him, "How you doing? How you feel?" "Pretty good." I was like, "Breathing okay?" "Yeah, no problem, breathing okay." And then one day he texted me, "I'm starting to feel a little short of breath." And I said, "Hey, Charlie, just come into the hospital. We'll check you out." He's like, "All right." I finally convinced him to come in. By the time he came in, he barely made it, So some of these patients, once you develop respiratory symptoms, things can change pretty quickly in a heartbeat. So respiratory symptoms are nothing to be played with. I think the patient needs to treat that very seriously. The doctor needs to treat that very seriously. And that's someone that we need to lay our eyes on those patients and our hands on those patients.
Well, I thank you, and I'm going to use the word again. You've been masterful as a presenter, and hope you can stick around for a bit. We have another presenter who is one of our famous presenters, Dr. Ron Bailey. And I'm going to ask Dr. Walks if he would introduce Dr. Bailey to talk about the other part of long haul syndrome regarding psychiatric effects. Dr. Walks?
I'm always happy to introduce Dr. Bailey. It's an honor to do so. Dr. Ron Bailey served as the 113th president of the National Medical Association from 2012 to 2013, serves as the Assistant Dean of Clinical Education at Charles R. Drew University and the Chief Medical Officer of Kedron Health Systems. Dr. Bailey received the Resident Research Award by the National Medical Association for his work on non-A, non-B hepatitis. He completed his residency training in psychiatry at the University of Texas at Houston and was chief resident in 1994. In 95, he completed a fellowship in forensic psychiatry at Yale University. He is now the chief medical officer at Kedron, and Dr. Bailey is a frequent guest and frequent teacher of ours, and we're honored to have Dr. Bailey join us.
And Dr. Bailey has announced to us that he is about to assume the position of being chief of psychiatry at LSU in June. He'll be the first person of color to hold that position. We congratulate him on that.
Outstanding. Congratulations, Dr. Bailey.
Thanks so much. Well, thanks the group for having me, like Dr. Maxey and the entire group from Black Health Trust. As Dr. Maxey mentions, this is an outstanding program weekly. I think I learned a great deal. I'd be remiss if I didn't start off by saying, yes, I was very proud to be, like Randall Maxey, a past president of the National Medical Association. I was number 113, but we're always very excited about new ideas and new people. And I see on this call today, you have our incoming president-elect, Rachel Villanueva, an OB/GYN from New York. Very happy that she's actually joining the group today. A few things to think about long hauler syndrome in psychiatry. A lot going on in this setting. I think Randall Maxey knows I'm actually at a church right now. We did FAME yesterday, first AME, and I'm at All Nations today. So we actually have a van. We actually go into the community and actually give vaccinations. Today we give Moderna and J&J. But clearly, I think the big issue, three big issues for the discussion today, I think, around long haulers in psychiatry are first and foremost, with the most prominent symptom being fatigue. Fatigue really is by definition a neuropsychiatric problem. Persons who are fatigued physiologically are also psychologically in deficit. They're often with memory loss and memory conflict and difficulty with word naming and word association. That's kind of historically many of the typical psychiatric symptoms that come along with fatigue. But many of the other types of symptoms that also occur also have a psychiatric underpinning, from headache, which is neurological, to many of the, we mentioned already some of the pulmonary problems of coughing, actually shortness of breath and tightness in the chest, and also some GI problems of diarrhea. So you really see a full constellation of concerns. And when that actually is in play, you have what we call constitutional symptoms that often lead to psychiatric depression and anxiety. Very commonly occurs when persons have chronic medical illness, and these so-called constitutional symptoms those can occur in a variety of settings with more than one type of clinical presentation in other multiple organ domains. As is often we see these classical so-called neurotic kinds of psychotic problems, to use an older term, and we've seen that, I think, in COVID-19 as well. The other unique aspect of long hauler syndrome that I was actually speaking about today is this idea that we can't really get our hands around its ending point. The idea that somebody perhaps has had COVID-19, perhaps been diagnosed and treated even in some settings, and there's a long ongoing process, particularly with the so-called brain fog, is what we most classically are seeing, and we're beginning to see persons kind of write about. And the fog is a little different than we see in some settings. The person just kind of can't have a word name, as I mentioned earlier. Often you're seeing kind of a full approach to memory concerns and really the sharpness of executive function, that part of the brain in the prefrontal cortex right behind the forehead, where you have abilities to think and concentrate, but also plan and make determinations, being able to drive in directions, be able to complete, meet deadlines, and complete activities you normally could complete in your thinking-related daily behaviors. We're seeing those substantially adversely impacted and impaired. The final point I mentioned, I think that we also recognize that this duality, I think, of these so-called neuropsychiatric concerns have a long history of leading to more substantive earlier mortality in persons with chronic medical illness. Rhonda Maxey is a renal doctor. By definition, if you're on dialysis and you're not handling your psychiatry well, your ability to manage your dialysis, to get there on time, to follow the rules and regulations, make it compliance, what have you, very often are limited and impaired, which may actually worsen your clinical progress. And if that's the case, you're more likely to have a longer period of incapacity, maybe even unfortunate earlier mortality. So all of the issues from the beginning, most serious problem of fatigue, to the other key issues of a headache and there's actually diarrhea and shortness of breath and tightness, if you will, and muscle aches and myalgias, we used to call them in the old days, if you will, all, I think, classically create a neuropsychiatric complex that we're having a hard time getting around. And because you don't simply see it get better, the neuropsychiatric problems, when the primary medical problem improves, that's what I think is confusing to those of us in mental health, because normally if the medical problem improves, the pneumonia or the diabetes complications or the congestive heart failure, if you will, then the psychiatric symptoms wax or wane as well. We're not seeing that here with the ongoing brain fog, and that primarily, Randall, is the problem with long hauler syndrome for psychiatry.
Thank you. Thank you. Are there any questions, Dr. Wonks?
Let me just ask Dr. Bailey, because you talked about the constitutional symptoms that impact the mental health. What we're seeing with COVID-19 are so many other things that impact people's lives. Folks who have lost their job or lost hours on their job, or who are isolated because of pandemic restrictions and those kinds of things. Can you speak a little bit about just how our world has changed so much and that additional impact on mental health?
Oh, absolutely. Thank you very much for the question, Dr. Walks. I think that a full array of additional concerns are coming to play for my patients and others. And our patient group is growing remarkably. I mentioned random vaccine earlier. You know, we're probably at about 3,000 vaccines. They did 3,100 yesterday at 3 different sites. They're actually opening more sites in Los Angeles. So we really are doing a better job, I think, in some of the earlier conversations we've had on this show with vaccine concerns and fears and reluctance, the operative term hesitancy. But we also, I think, are still appreciating that even as we vaccinate more persons, there are more problems, I think, in the box we have to kind of address. Those type problems that you, I think, speak to, I think, very wisely are those that we've kind of had long term. I mean, persons come into this equation with a prior, grab bag, so to speak, of other barriers to quality psychiatric and psychological health and other difficulties. Many patients struggled well before COVID-19, if you will, with fiscal difficulties and employment difficulties, family concerns, if you will. I'm in a large city now where I think many of the challenges of urban life are substantial. And very often those individuals who may actually struggle, even when resources are brought to bear. many of our patients have not received the $1,400 check and have not been able to kind of pay off the bills that were due. And some actually who did receive it had bills of more than $1,400 if they had not paid rent in not only 1 or 2 months, but 3 or 4 or more. So those kinds of, I think, psychosocial stressors are the classical issues that I think revolve around this long historical pattern of the social determinants of health, living in communities that very often lack adequate resources, being underemployed or if not unemployed. So fiscal challenges, I think, are greater. Having family challenges that may be even more enhanced. Multi-generational families with older relatives that may struggle in the healthcare domain from a health perspective, also from a fiscal perspective. And even I think younger persons in educational and early employment opportunities, when those are not there, then that actually I think carries over to much more substantive difficulties for families that we care for, I think, in inner city populations. I end by saying I think another challenge for us going forward is going to be, the future is bright in some segments of communities and not in others. So one wouldn't want to have communities that are left behind in other areas. And when a health challenge like COVID-19 comes into play, it just compounds the problem and stresses resources that have historically been under in great demand for a long time. Those challenges, I think, are much more problematic, I think, for our patient population. And we as a community, I think, must find better, more effective strategies to employ going forward. I hope we can do so with educational programs like this.
Thank you, Dr. Bailey. Dr. Maxey, there was a question in the chat that if you don't have anything right now, I can go to that.
Go right ahead.
Okay. Dr. Bailey, there were two questions that that are in the chat that I'll just kind of run together. One of them asked for recommendations for alleviating brain fog. And then along with that, there was a question that asked about other treatment approaches with respect to psychopharm, cognitive approaches to help the person function better. Psychotherapy, it's sort of like we've identified what some of the challenges are. So if you can speak a little bit to some of the interventions, there's another question that just popped in about specific drugs such as fluvoxamine, Luvox, that kind of thing. So maybe you can talk a little bit about what are some of the interventions when we find someone with all of those things that you've just discussed so eloquently. What do we do?
Yeah, right. Three things. First, I think an early short-term and pretty direct intervention that's psychopharm-based would involve the use of some of our tried and true long-term meds that are very safe in this regard and have really a duality of beneficial both in the depression domain, but also in the anxiety domain. Those come in a category of SSRIs or selective serotonin reuptake inhibitors. Someone I think did put in the chat, there's one that has historically been good, not just for clinical depression and anxiety, but also a pretty specific type of anxiety called OCD or obsessive compulsive disorder. Those are also with obsessive thoughts. That medication, fluvoxamine or Luvox, has been shown to be very good in that regard. And I think that it'd be very important for us to see over time, or initially, I think with open label trials, but over time, with something that's a bit more gold standard, it's actually particularly beneficial in the COVID-19 group. But I'd be very comfortable as a psychiatrist considering the use of SSRIs, especially a treatment like Luvox in this type setting. We do have great data, though, on other more potent treatments that are not just for depression and anxiety, but address really a wider range of treatments, including bipolar disorder, where some of these same types of cognitive challenges can occur. Those fall in a category of so-called atypical medications because they work both for more than one type of problem in psychiatry. We call them atypical. Typically, treatments just have one diagnosis and work for one type problem. So the best data is on meds, Seroquel or Zyprexa or olanzapine and clozapine. I mentioned earlier the term word naming, which is a classic particular type of a cognitive deficit that occurs in individuals with some of these kinds of problems. And we've seen some of that over time with the brain fog that can occur with COVID-19. We probably have to get to a point of more functional compromise in a patient in psychiatry before we use those bigger type agents. I think starting off with SSRI probably is better before moving to a bigger type item. But if you think about the patients who may actually come in and long haulers fall in this category, they're more likely to occur in persons who had more medical compromise up front. So more likely, if you had hypertension or congestive heart failure, diabetes, asthma, history of pneumonia, would you be a long hauler, somebody who really cannot get past the initial exposure or diagnosis of COVID-19? So I think that's probably something for us to look forward to, look toward going in the future. The third point I mentioned is therapy. Somebody mentions therapy. By definition, I think that persons who actually are already in therapy are likely to get some benefit. And I like to, as a Black psychiatrist, often say that many patients in my career receive therapy without going to a doctor's office or seeing a doctor with certain initials behind their name, psychiatry, psychology. Many get therapy in settings with persons who they trust. It may be somebody who's trained in the area, or somebody who's trained in a different area, like religion or spirituality, their pastor, their priest, someone who's actually trained in a covariant area of medicine, a nurse or social, if you will, who's a friend or colleague. And I like to encourage that rather than discouraging people from going to therapy if it's not in a more formalized type setting. Because by definition, the Therapeutic Alliance is the most important aspect, I think, of a therapeutic exchange. And if somebody has something on their heart that's weighing heavy, being able to get it off your chest and get information, whether it's advice or simply support from someone else who you believe in and trust, who does so from a mission-based perspective in a way that you believe in, and you're likely to actually engage in what they share and implement some of those strategies, is likely to work. So the example would be, I might need to see a psychiatrist to tell me to stop drinking, but I'm drinking a lot and it's causing me difficulty. And my best friend is a nurse or what have you, and we talk to them, or my colleague is a social worker and I engage with them, or past classmate, and they can engage with me in a way that actually encourages me to change behavior in a more effective way. That's actually a very, very good thing. I end by saying that is what I've thought about for so much time during this period. Let's discuss the vaccine limitations. We had access to the vaccine, or the vaccine was going to be taken or pursued by certain communities that had these past issues of mistrust. Very often, these are strategies to find individuals who members of our community do trust and would choose to pursue actually getting a vaccine. I'll end by saying I'm at this church that was Southern Randall Maxey, in part because the people here felt more comfortable if I came here to see them today, because their pastor was going to actually get the vaccine. And then go without saying, that's somebody who they trust at the highest level. These are some strategies we actually tend to need to use, I think, and have to work.
Let me ask a question of Dr. Salafou, Dr. Fornjay, and Dr. Bailey. We have a term called the microbiome. And early on in the Black Health Trust, we had talks about treating the microbiome. And we know that the gut, as Dr. Fornjay told us, is often an entry point of the virus. And when you speak about drugs such as Seroquel and things such as 5-HT that affect the psyche, how do we tie this together with either non-pharmacological treatments? How much does this microbiome and the gut play a role in long-term long haul syndrome? That's to all three of you.
Bob, you want to take this if you are still there?
I would say there's very little information on that right now. One thing I would say is that certainly antibiotics disturb the gut microbiome. Anytime we take antibiotics, we're killing the normal bacteria that reside there and changing the flora, so to speak, what organisms are living in our guts. So it's not an unreasonable idea to consider supplements to restore the normal microbiota, so to speak, of the gut after a COVID-19 infection, particularly one with respiratory consequences, because frequently those are going to be treated with antibiotics that could have an impact. But certainly that's an area that warrants further investigation. And we already know from irritable bowel syndrome, from ulcerative colitis, that there's a huge psychiatric and neuropsychiatric component for these gastrointestinal diseases.
Thank you. Any other speakers care to comment on that area?
This is Ron. I just jump in and simply add that clearly I think the jury's still out. There's a lot to be determined for us, and what some of the and many of our prior concerns along this new issue COVID-19, what some of the causative indicators are. One thing we're very clear about in psychiatry is correlation, and all too often correlations between you mentioned the microbiome between the gut and imbalance thereafter have historically been substantially problematic, I think, in various forms of mental health. Issues regarding feeling sad, depressed, and anxious, and then having a stomach ache and complaining of such. Some of the early data that I published indicated that Black women were much more likely to complain when they had clinical depression as an end result of a stomach ache than really any other particular type symptom. So I think in our community, we should be very mindful that not only do we have one consideration, that there may be have been a stigma against having brain illness or mental illness, psychiatric concerns, because of the religion focus that I've often talked about throughout my career. The person thought that you were not right with God if you described having a psychiatric or depression or a emotional level of imbalance or a deficit. But the other issue I think you also, we perhaps should be mindful of is the reality that we probably have often tied GI issues to mental health issues or concerns in a way that I think has made them dually important as problems, I think, symptomatically, but also dually difficult to treat or to manage, I think, over time. That this will be, I think, an issue raising its head now, Dr. Maxey, is not surprising. This has been kind of part of a pattern that we've had a hard time getting our hands around and managing well in psychiatry for some time.
Well, thank you. Any comments, Dr. Salafou?
Well, I think I like the answer that Dr. Foronji gave. The gut microbiome is there for a reason. It's there to keep the balance, and it's a balance between the good and the bad, so that you don't have preponderance of the bad. But when there's alteration in the microbiome, then you're going to get alteration, and you're going to get more of the bad than the good. So the replacements that we know about are not scientifically validated. So it's very hard to actually pinpoint a study saying that you replace the gut microbiome, you get an effect, psychiatric effect, which is positive. It's very hard to pinpoint that. But there are associations, there are relationships, and those relationships are well studied in IBS, irritable bowel syndrome, I think, in depression, like Dr. Bailey said, and in other psychiatric disorders, that when the microbiome is disturbed, you have effects that are way, way beyond the gut. The question really is, if you replace the microbiome and bring it to normal, whether you can actually ameliorate that relationship, and that's what we don't know. It would have been nice to know to have a way of studying the microbiome. For instance, you take a stool sample, you can measure the microbiome, and you can see, for instance, we have identified 50 million microbes, and it's a lot of microbes, and I'm saying the right word, they're actually in the millions, 50 million microbes. And then you can pharmacotype them, or you can genotype them, and then be able to replace them more specifically. That is what we're lacking right now. That kind of science is way, way more than what we have right now. But I think that is where the science should go. We should be able to take a stool sample, either pharmacotype it or genotype it, and be able to say this is missing, and then just replace that missing thing, and be able to study whether it has an effect on the symptoms or not. That part we don't have yet.
Well, thank you so much. I'd like to thank all of our wonderful speakers today, Dr. Foronji, Dr. Salafou, Dr. Ron K. Bailey, for giving us a wonderful discussion. I want to, if Yukini is on, just tell us who is our program for next week.
Yes, give me just a moment and I will share my screen. Next week we have next Sunday, April 18th, we have Dr. Bailey back again with his team with part 2 of his talk on intimate partner violence and evidence-based approach. So we'll have Dr. Bailey, Dr. Stiff, Dr. Williams, and Dr. Rogers as our guest speakers next week.
Okay, Dr. Stiff is Dr. Deborah Proto-Stiff, who's the Dean of the College of Medicine at Drew, and who are the others?
We also have Dr. Mallory Williams. He's the Director of Trauma and Violence Prevention Center at Howard University, and Dr. Roger Mitchell. who is the chair of pathology at Howard
And
University.
who is the previous chief medical examiner for the city of DC. And
Hey,
who
is
is
Dr. Maxey, Ron
Yes.
Bailey. Yeah, in the book on IPB, and I thank you guys very much for giving us this 3-part series. We have a third group coming May 23rd, but the person who wrote the chapter on COVID-19 is Mallory Williams, a surgeon, chief of surgery and trauma surgery at Howard University. Wrote 2 chapters in the book, one specifically on intimate partner violence and COVID-19. So I think his comments would particularly are beneficial. Deborah Stither, you points out, is the dean here at Drew. Her long history of career and violence work. So, and Roger Mitchell speaks for himself, just the leader, I think, of our violence task force in NMA. All 4 of us on that task force. Roger Mitchell, the new chair of pathology, mentions at Howard, is the chair of that task force as well. So, look forward to the group next week. Thank you guys for having us.
Okay. And
Dr. Maxey, let me just say, knowing several of the folks who are coming on next week, especially knowing Deborah Prothero-Stith for 20 years, more than 20 years, such an exciting group. I'm really excited about the meeting next week. Wow.
that's something we're being very gifted to have the caliber of speakers that we have. And I believe we have coming up on May 2nd, a gentleman by the name of Francis Collins, who's the director of the National Institutes of Health, and he's Dr. Fauci's boss, and we have others coming. So look for us to elevate our programs on a continued basis with the doctors that we have. I want to bring the fact that some months ago, our audience said that they wanted us to put together a panel of respected physicians of color who could advise them on second opinions that they might need in their healthcare, but also first opinions. And we've done that. And a number of the speakers that you have seen over the past few months and in the future have chosen to join us with biometric second opinion. And if you go to our website, you can take advantage of that. I've been able to speak to some of these ladies and gentlemen, and the level of consultation that they're able to give is so important and so great. And I've seen a number of my family members have those consultations as well, not just about COVID, not just about health disparities, but about connective tissue disease, arthritis, psychiatry, everything. We've got a great pool of talent among physicians of color. Most of us are members of the National Medical Association, and we just believe we have a lineup of doctors in that group that are world class. And we have been fortunate to have many of them join us here on the Black Health Trust, and we hope to offer this as a service. As you know, we are a nonprofit organization. We depend upon your support to continue our programming. We're starting to expand, and we're looking for any input that you can give. And lastly, I'm going to convene a meeting this week of individuals who would help us with our grants. And we have a small committee. I would like those who would like to assist us in that way to join Dr. Walks and myself and Dr. Barbara Stevens, help us get the right underpinning for the organization we need to continue. And we thank all of you for joining us today. We invite you to come back again next week for our program. Is Ms. Brenda Lee Yeager on?
She is not. She's serving at church today, but she asked me to send her blessings and love to everybody. And so I'll just read an affirmation that I put in the chat room. It's from Dr. Martin Luther King, and it says, "Everybody can be great because anybody can serve." So I'll leave you with that.
Well, thank you. And we do have the distinguished Pastor Reverend Pointer on, and I would like his benediction if he would be so kind.
Thank you, Dr. Maxey. Thank you to Dr. Faranji, Dr. Salaflu, and Dr. Bailey for sharing with us such intricate knowledge of long haul syndrome, and especially for addressing the social effects, because we often seem to forget that our head is attached to our body. So it's such great. Let's give thanks. Eternal Lord God, our Father and Maker, creator of all that we know and see, we thank you for another time of sharing together, that you continue to knit the fabric of this community, that you knit our hearts together in concern for one another. We thank you for these men and women who you have sent, who have prepared themselves and who continue to delve into their areas of specialty and then to extend themselves beyond that. We thank you for this time together each Sunday afternoon. We ask, O Lord, that you will continue to give our hands work to do that will be pleasing in your sight. We ask you to dismiss us now from this congregation, but never from your presence. In the name of your Son, Jesus the Christ, we pray and thank you. Amen.
Amen.
Thanks,
Bless you.
everybody. Appreciate our speakers. Thanks, Dr. Walks.
Yes,
Take
sir.
care out there and don't forget to visit the website, blackhealthtrust.org. Have a great week, everybody.
Bye, everyone.
Praise God. Good stuff.
Hello. Hello.